Dr. Jindal to
Thank you. Post-lunch, teaching about ultrasound may be slightly making you sleep, but we'll see how we can keep you awake. I don't have a disclosure. I come from the north part of the country. You see, purpose of ultrasound is if you are really going for an access, the ultrasound is a must. And I think in this whole session, Tushar is here, me, and speakers next to me, we'll all be stressing you ultrasound, ultrasound, ultrasound. Because I personally feel, I've been using ultrasound from 18 years now for access. And, we started with just a basic marking, then bit more, then physiology, then pathology, and then ultrasound guided punctures. Then we got into ultrasound guided angioplasty 10 years back. So now I feel that if I have to do access, I am totally blind. I actually cannot do without an ultrasound. So ultrasound is so important. So this talk will be only on how an ultrasound can be used on pre-operative. I think rest of the speakers, I'm not going to indulge in their talk, because they are going to talk to you about the importance of ultrasound overall in an AV fistula management. It's very, very important. So as a nephrologist, you are a physician, you can pick up the skills very fast. And I think in the beginning you may have some difficulty, but there are a lot of courses being run by the Avatar, and you need to get into ultrasound. So whatever hitches you have, PNDT and whatever, you need to get there. Okay, you need to break them, but without an ultrasound, you will not be able to move further. Okay, and that is also an ultrasound to be done by yourself, not by the radiologist. So I'm not against radiologists, but if you want to get into this field, you need to learn ultrasound somehow. So AV fistula and graft, they are different. Assessment pre-operative is also different for both of them. So we will mainly talk about the fistulas because I feel that's the most important thing in our current scenario in India. We need to know the basic anatomy before we move on. A cephalic vein which runs from the top here, goes down, joins the medial cubital vein, runs along the radial artery up to the base of the thumb here. Basilic vein is deep here, goes down along the elbow up to the ulnar artery. And the brachial veins which runs along the artery. So in the beginning you get confused, which is brachial, which is basilic. So we need to know the anatomy. So I have put in a very basic talk, but we need to know at least this basic anatomy before you move further. Now this is a very important slide because it shows the diameter. Let's say the basilic vein here is 5 millimeter. The depth is around 4 centimeters. And after tourniquet, it becomes 7 millimeters. So these are the normal basic diameters of all the veins in the arm, and pre and post tourniquet, and along with how much depth normally these veins are situated. So that's why the radial artery is very good because it's only 3 millimeter at depth, the cephalic vein. And so that's why it's a very good vein if we have for doing the anastomosis to the radial artery. And these are the three basic main anastomosis we all do when we do a fistulas. One is the radiocephalic here, cephalobrachial, and the basilic vein to the brachial artery. So of course there are, you keep on going, but we start with this. In terms of preoperative strategies, we try to use the upper limbs, always try to use the non-dominant arm, and AV accesses place as distally as possible because they will run for longer time as compared to the proximal ones because of the flow-related stenosis you will get in the proximal AV fistulas. And AV fistulas are better than the grafts, we keep on telling, except in certain situations like obesity or the veins are not there. And in terms of configurations, we should try to do a direct anastomosis followed by transpositions and translocations. So this is what is there. When you want to do an ultrasound, we start learning with some basic things. As I told, you should learn the ultrasound, and it's not really difficult. And you can be actually, if you just have to learn the arm ultrasound, you can be trained in 2 days actually to know the basics of ultrasound. It's not very difficult. You should try to use a linear probe, maybe around 7 to 10 megahertz. Always try to have the room warm, apply a tourniquet, and you should do a venous and arterial Dopplers. And there are two things which you should know by the gain and the focal depth. And when you place a probe on the veins in the beginning, the biggest thing is you need to be gentle, because otherwise the pressure of the probe only will compress the vein. And should apply a plenty of jelly, because you don't want an air to be in between the probe and the skin, otherwise you will not be able to see the veins. And also you need to put in a pressure of your hand on the body so that you can hold the probe in the air actually, slightly touching the skin, no pressure on the skin of the probe. So that will give you the best pictures of the veins. In terms of arterial evaluation, we should look into the normal pressure inflows and not to make too big anastomosis to avoid a Steele syndrome. And we should do the clinical examination of all the basic arteries, do the blood pressures. Allen test is controversial. I personally do it because it takes me only 1 second or 2 seconds to do it. It doesn't take too much time to do it. There is no harm in getting it done. And ultrasound, we should look into the arterial lumens. I personally, you can start with arterial or veins. I start with arteries because I feel after that I will apply the tourniquet. Arterial evaluation has to be without the tourniquet. So there is a difference between that. And so once you start the arterial evaluation, you start from cephalic, or from the cranial to cephalic here, from the axillary subclavian arteries going up to the radial and ulnar arteries, and look for signs of atherosclerosis, because all these kidney failure patients has got a lot of atherosclerosis. You should also look into the arterial triphasic waveform, what we call this, and in some patients you may have a biphasics in radial and ulnar. That should be normal for these patients. You should also look at the diameters. We need at least 2 millimeter diameter of any arteries you do the anastomosis, because if you do a lesser than that, your fistula failure rate will go up to 40 to 50%. So that's the difference. So try not to do the anastomosis in less than 2 millimeter arteries. Look into the calcification, velocities, thrombus, and the arch. Now this slide, as you can see, this is a calcified radial artery. I will prefer not to do an anastomosis unless I am forced to do, because there are too many things which can happen. One is later on, once you have done the fistula, this artery may not dilate. So if this artery may not dilate, it will not be able to give you enough flow. Second is, while doing the anastomosis, you can have bleeding. And once you should be mentally prepared that only tourniquet may not be able to control your bleeding. You may need a clamps. You may also need an intraluminal balloons also to control the pressure, because sometimes the clamps can crush the arteries. While you're doing the anastomosis, you can cause the dissection of the arteries. So all these things, they should go into your mind when you see such bad arteries on an ultrasound, and you should be mentally prepared that unless the vein is very good here, maybe more than 3 millimeters, I will not do the anastomosis here. If the vein is also poor, like 1.8 millimeter here, it's better to avoid this area and go to the next level vessel. Because you know, India scenario and Western scenario, you need to see the practical ways, because finances is also, you need to look into your mind when you are deciding what level anastomosis you want to do. So that's why ultrasound is important, because it can take your success to 98% approximately, and if you do it properly. Similarly, venous assessment you need to do, and start from cranial and caudal and look up all the veins, the diameters, the distensibility, the thrombus. And more than 2.5 millimeter is a basic diameter what we require in the veins. Then you look into the compressibility and the side branches. What happened here? I don't know why it has gone all white. Anyway, vein assessment is very important to look into the patency. Patency is very important because you just compress it with an ultrasound and look at the compressibility of the vein. If the vein can be compressed, means it's patent, so there is no thrombus. So that's very good for us. Also look into the accessory veins, because if you have a very big accessory veins, more than 8 millimeter, and in less than 5 centimeter area of your anastomosis, then the fistula may not mature. So all these things you can identify on an ultrasound very clearly, and you can decide the level of anastomosis. Pre and post tourniquet is also very important, because if your vein does not get dilated after tourniquet, at least 50% distensibility should be there once you apply a tourniquet on these veins, so that you can identify that these veins will dilate once you make an AV fistulas. I really don't know what has happened to these slides. Venous distensibility, anyway, it doesn't matter. Venous distensibility is also very important. So once you have applied a tourniquet, so the tourniquet should be applied for approximately 2 minutes, and then you look into the veins distensibility, and once you see the veins are getting distensible, so it's a good feature that you will get a very good flow into the AV fistulas. So veins, as I told you, should dilate approximately for more than 50%. It's a basilic vein pre and post tourniquet, so which is very good for us. Then you should also measure the distance between the cephalic vein and the brachial artery, because this is very important, how much mobilization you have to do. So this all things you can decide on ultrasound, and you can also see how you're going to place your incision, because same incision may not work in this case, where the vein and the arteries are far away. Coming to central venous assessment is very important in all our patients, because all our patients have a primary line or the permacath protein before they come for fistulas. We do in our clinical patients clinical judgment. What you can do is distensible IJVs, lot of dilated veins on the chest, dilated veins on the arm, you've got a swelling in the arm. So that puts an indication that this patient may have a central venous stenosis. Then you need to do an ultrasound and, if required, an angiography before you make a fistula to make sure that the central veins are normal. So you can have an indirect measurement also by doing an ultrasound. You can have a phasic variation. If you have a phasic variation on an ultrasound, means the central veins are normal, so you can make a fistula. So all these are indirect evidence which are normally sufficient enough for us to do that.
Time is up,
yes,
Dr.
please.
Jindal, sorry.
Last slide, please. So you can report like this, and this is the clinical maturity, how it looks like. And this is the last slide. An ultrasound matured fistula should have a 6 millimeter in diameter, and it should be less than 6 millimeter below the skin to have a sufficient puncture. Thank you.